Hello everyone, I'm Zhao Yaping, come from First Hospital of China Medical University. Today, we are talking about interstitial lung disease. So, interstitial lung disease, also called ILD, or diffuse parenchymal lung disease, is DPLD. So, what is ILD? ILD is a group of lung disease affecting the interstitium, most of which cause progressive scarring of lung. It concerns alveolar epithelium, pulmonary capillary, endothelium, basement membrane, and perivascular and perilymphatic tissue. Now, let's review the structure of the lung. The trachea divide into right and left bronchi and the lower bronchi and so on. The ends of the air sac, so-called alveoli. The alveolus is the main gas exchange area of the lung and is composed of a thin epithelial layer supported by its basement membrane, a capillary endothelium supported by its own basement membrane, and the interstitium between the two basement membranes where two basement membranes are fused. The alveolus is optimized for gas exchange. This region is known as the thin portion of the blood-air barrier. In the thick portion, by contrast, the basement membrane are separate and there are fibroblast, collagen, and elastin fiber and contractile intercells. In ILD, the basement membrane of alveolar epithelial and capillary epithelium hypertrophy and interstitium proliferation was seen in the lung. The blood-air barrier becomes thickened and it's not so easy for oxygen to go through. Then the patient will develop hypoxia. Now, I would like to show you some clinical cases to explain what is ILD. So, case 1, male patient, 7-8 years old. The chief complaint is shortness of breath after activity for 2 months. The symptom was 2 months ago, he felt shortness of breath after go upstairs, but could not find any reason. Dry cough, no fever, no chest pain. For the physical examination, bilateral microcricles could be detected on the chest, oscillation, clapping fingers, and cyanosis. So this picture shows clapping fingers. You can see hypoxia at the end of the finger or toe, hypertrophy, and the clubbing expansion. It's characterized by the widenings and thickenings of the end of the finger segment and the uplift of the finger nail from the root to the end, so that the basal angle between the skin and the fingernail on the back of the finger end is equal to or more than 180. So the CT scan showed basal and subpleural predominant reticular pattern with associated traction brachectasis and honeycombing in the basal lung. Lung function tests showed forced vital capacity, which is FVC, was 67% of predict, and the forced expiratory volume in 1 second FEV1 was 81% of predict, and FEV1 versus FVC was 82%. And the diffuse capacity for carbon monoxide, we called DLCO, was 55% of predict. So the conclusion was middle restrictive lung defect, middle diffuse capacity decrease. For the laboratory findings, the blood routine examination was normal, and the routine urine analysis was normal, and blood gas analysis showed PaO2 was 67 and PaCO2 was 41. This is hypoxia. And for the IgG, IgA, IgM were negative, and ANA was positive, but other CTT biomarkers were negative. All the tumor markers were negative. So the diagnosis was IPF, that is idiopathic pulmonary fibrosis. So the case 2 was female, 74 years old. The chief complaint was cough, short nasal breath after activity for 6 months. The symptom was 6 months ago, she felt short nasal breath after go upstairs, but could not find any reason. Dry cough, no fever, no chest pain. She had joint pain for both hands and morning joint stiffness and renal phenomenon for 20 years. For the physical examination, bilateral microcrackles could be detected on the chest, oscillation, clapping fingers, cyanosis. So we asked for his history. She has rheumatoid arthritis for 20 years. So the CT scan showed basal and subpleural predominance reticular patterns, ground glass and reticular shadows in the lower lung, no traction bronchiectasis, and honeycombing. So the diagnosis of this patient was connective tissue disease related ILD. The connective tissue disease was rheumatoid arthritis. So the case 3, female, 53 years old. The chief complaint was shortness of breath after activity for 3 months. The symptom was 3 months ago. She felt shortness of breath after go upstairs. Dry cough, no fever, no chest pain, no joint pain, no morning joint stiffness, no renal phenomenon. For the physical examination, the chest oscillation was normal. No clapping fingers, no cyanosis. The chest CT scan, that is HRCT, show a reticular nodular interstitial pattern at the bilateral lung bases, bilateral hair and the mediastinal lymphadenopathy. So the contrast-enhanced CT scan showed bilateral hilar and mediastinal adenopathy. So the diagnosis for this patient was sarcoidosis. So case 4, male, 33 years old. The chief complaint was shortness of breath after activity for 6 months. And 6 months ago, she felt shortness of breath during carrying something, but could not find any reason. Dry cough, no fever, no chest pain. For the physical examination, chest sound was normal on chest oscillation and clapping fingers. So the CT scan showed big infiltration in both upper lungs with reticular linear. So we asked for his working history. She had stone milling for 5 years and agate manufacture for 5 years. So the diagnosis of this patient was pneumoconiosis. So now we come back to see what is ILD. So ILD is a group of disease including acute and chronic diffuse parenchymal lung disease with many important features in common. So these orders are heterogeneous. So in this part, we are talking about the conception of ILD. We will talk about classification in next section. Goodbye.